So, Gareth, welcome. Thank you so much for joining me for this. This is something that a lot of my therapists, whether it be reflexology or massage therapists, or even beauty therapists that are doing foot treatments, have probably been told you can't treat a diabetic foot, and they get very worried about treating the diabetic foot, so want you to put them right on that, but also making sure that we are the link between vulnerable clients and ensuring that the referral process and the communication is as good as it could be. So I'll let you introduce yourself and what you do, and take it away, Gareth. Thank you so much.
Okay, well, thanks for the invitation. Hopefully you've all got a slide up in front of you at the moment. Don't worry, there's no nasty pictures coming up. I'm more than able to give you plenty of ulceration pictures, but I'm not going to do this. The whole idea is to just raise awareness, really. I'm not here to frighten you into anything at all. It's just raise awareness on what could happen and what your role is, because you're basically in the front line. And you have the luxury of having a relaxed client with you, which means that that client may share a little bit more than they would to somebody in a white coat or a clinic. Because very often when people come and see people like us, they clam up, they're nervous, they're anxious, they forget things. But in your environment, you're going to have much more of an opportunity to discuss things with them. And they may be a little bit more free about sharing some information. So just to let you know a few little bits and pieces, really. I should introduce myself. I'm Garath. I qualified as a podiatrist a very, very long time ago. We'll just say last century and leave it at that. I worked in the NHS and in the private sector, and the diabetes has always been a little bit of a passion with me, because so much of the issues that the patient has are avoidable if they just have that little bit of information at the right time, which is why we're here today. So if we set the scene a little bit, I'm not going to insult your intelligence and read off the slide. You can have a little look through some of these statistics. They're a little bit grim. At the moment in the UK, we've got around about 4.5 million diabetes patients who've been diagnosed. If you look at the charity called Diabetes UK, they reckon there's another possibly 1.3 million out there who remain undiagnosed. So it's quite a significant problem. It's around about 6 to 7% of our population. And if your catchment area includes a high Chinese or South Asian or Afro-Caribbean population, they will have a higher rate of diabetes in that little group as well. So the statistics here apply mainly to England. Obviously, we have diabetes patients in Wales and Northern Ireland and Scotland as well. But most of this is aimed towards the English market. The trouble is, once you start broadening it out, working with different healthcare systems means some of the stats don't always match up. So with all of this in mind, one of the things we want to avoid is ulceration. I'll go into details about what that is a few minutes later on. And you may wonder, well, what's that got to do with me? But what we're after is for patients to keep both feet and keep them intact. So when they come in to see you for their reflexology treatments or sessions, then if you see something you're not sure of, or during that conversation, you can share a little bit of the information that I'm about to give to you. One of the things we do ask at this point is if you're aware of diabetes at all, and whether or not you'd like to keep up to date with what's going on. In terms of asking the client, we ask all therapists, foot health practitioners, reflexologists, nail and beauty care technicians, we ask them all to ask their patients, or their clients rather, are you a diabetes patient? And if you are, do you look after your feet? Are you aware that things can go wrong with your feet? Because some of the diabetes patients don't. You have to bear in mind, when they come and see us, like I said before, they're usually nervous. Okay, it always makes me smile that we ask patients to come in and have a blood pressure taken. It's always higher than it should be, because they're nervous because they're having a blood pressure being taken. And it's the same when they come into me with feet. If they're looking at they're talking about diabetes patients, when they come in, they're a bit anxious, and when we're asking questions, it's a yes/no situation. It's almost like an interview at times. So you're at a much of an advantage over us because the patient is more relaxed with yourself, so you'll probably get a little bit more out of them. We tend to frighten them, not on purpose, it's just the anxiety of coming to see a clinician. In terms of treatment, if the patient has a fungal nail infection or athlete's foot or an ulceration or cuts, it's probably a good idea not to carry out one of your treatments. With psoriasis patients, you still can. It depends. Psoriasis is a skin condition where if you look at the normal skin turnover, it takes around about 25 to 28 days for us to completely replace our skin. You may say, well, where does it go? It falls off us all the time. So I'm afraid next time you're dusting your house, you're actually moving away a lot of your former self. That's where a lot of the skin cells fall to. With psoriasis, it's an immature cell maturation. So it means that those cells come to the surface a lot quicker than they should do. So they're immature. They look like little plaques, usually a silvery grey sort of plaque. And if they're affected on their feet, then it's probably a good idea to consider and make sure that the patient is happy to have their reflexology carried out. But in terms of fungal infection like athlete's foot, it's probably not a good idea just to leave it alone because you can spread it. It's a fungal infection that's spread by touch. So we ask you just to leave it alone, go and get it treated, and then come back to you when they're nice and clear. We've been asked to explain what diabetes is. It's a metabolic disease, which is when we talk about metabolism, that's how your body moves forward. You feed it with food, it processes that food and turns it into energy. And one of the main problem with diabetes is that it's high levels of blood glucose. Okay, you may have heard of the term hyperglycemia. That's just a posh word for high levels of blood glucose in the blood. If any of you have family members, they might be on about their BGLs, their blood glucose levels, or I've got too much sugar in the blood, etc. Essentially, what happens is there is such a thing as normal blood glucose, and this fluctuates throughout the day. So if you have a breakfast of, say, I don't know, cornflakes, that's got carbohydrates in. Look at the side of the packet, you'll see how much carbohydrates are in. It's usually a 30-gram serving. That goes into your tongue, it gets processed as carbohydrate, and that goes into the blood as glucose. At that point, your blood glucose will go up. And then what happens in the non-diabetes patient, we have insulin that comes down from the pancreas, and that opens the cells so the glucose can come from the blood into your cells. The best way to think of it is like a lock, essentially. So when this glucose is floating around in the blood, the insulin comes in and it allows that glucose to be removed from the blood and put into the cells. Every cell we have, be it cells in your hair roots, cells on the side of your blood vessels, the back of your eyes, the skin on your feet, everything needs some energy, which is delivered by glucose. So that's what insulin does. It allows that source of energy, that glucose, to move from blood into the cells. That's what insulin does. Okay. There are a couple of different types of, well, there's 4 or 5 different types of diabetes. Type 1, out of those 4.5 million patients who have been diagnosed in the UK, around about 8% of them have type 1, which makes around about 350,000, I think, something like that. So type 1 is an autoimmune response. It very often comes on after a viral infection. Usually in school children, it can be primary school age. Occasionally they can be diagnosed sort of early teenage as well. And essentially what happens with type 1 is that insulin production stops. They cannot produce their own insulin. So this is why the type 1s have needles, so they can deliver insulin across the skin directly into the body. It's not possible to give patients insulin orally by tablets. Because insulin is actually a protein. So if it's taken in by the mouth, it goes down into the tummy, and it then gets absorbed and broken up. So it doesn't actually work. It gets broken up as a protein. So to get insulin into the body, the only option we have is across the skin by needle. So for those of you who do know patients with type 1, you'll see them with what looks like a big thick pen, about sort of 5-6 inches long, and this will have a little file of or a little cartridge of insulin, and they'll pop this in on or around the time when they eat. And generally speaking, most type 1s have 2 insulins. They have a long-acting one, which they pop in once or twice a day, and that sort of dribbles a bit of insulin throughout the time, and then they will inject around about the time they eat, depending on what they think the amount of carbohydrates is in a meal. So a lot of type 1 diabetes patients are very aware of pastas, baked potatoes, as well as your sort of your sweets and fruit juices, and many things have got carbohydrates in it, and that's what the type 1 will concentrate on. He or she will look at what they're about to eat, estimate how many carbohydrates in there, and take the relevant amount of insulin. And these days you may see people with little plastic discs on their arms, or a little oblong thing, and that's what we call a continuous glucose monitor, CGM. So that has got a little thread that goes into the body. It measures your blood glucose, and it transmits that measurement to the smartphone. So I think just about 100% of type 1 diabetes patients now have a smartphone which will tell them what their blood glucose is at any time. And they can set an alarm to make sure it doesn't go too low, and they can set another alarm to make sure it doesn't go too high. And what this means is that the type 1 will get a lot better control. So if you do see the patients with a little disc on their arm, that's probably what it is. Okay. With type 2 diabetes, basically the patient does have insulin, but they're either not producing enough or that insulin doesn't work properly. They have almost like an insulin resistance built up. So this is the vast majority of patients in the UK and across the world for that matter are type 2 diabetes. Tends to happen later in life. Many years ago when I first qualified, we used to call it maturity onset diabetes because most patients were 50, 55 plus. But now we're getting people, in some cases, some teenagers with this type of diabetes. So we call it type 2 diabetes. So they have insulin, it's just not enough, or it doesn't quite work properly, and that elevates the amount of glucose in the blood. There are a few other types of diabetes around as well. Gestational diabetes is one where, while mum is carrying baby, mum develops diabetes. Usually within about 12 months after baby is born, that diabetes disappears, but it does mean they're more likely to develop diabetes later in life. And there are a couple of other very rare types of diabetes around as well. So that's a sort of a snapshot of diabetic medicine, if you will. What does this cause? Well, high levels of blood glucose are toxic to the body. We're not supposed to have that much glucose in the blood. So this is why a lot of diabetes patients will talk about their blood sugar and how they've got to keep an eye on their diet, etc. If they have persistently high levels of glucose in the blood, that's when damage happens, and it can happen over a long period of time as well. So with type 1 diabetes patients, little Johnny in school he may find that he's wetting the bed a lot, or he's drinking a lot, and he's got quite a short, what we call onset. So it's usually days or even weeks, and mum and dad think, well, something's not quite right, and off you go, and it gets diagnosed pretty quickly. With type 2, it's what we call an insidious or a very slow onset. So if we see patients who are symptomatic, which I'll go into in a few minutes, it could be they've had diabetes for a number of years without realizing it. And they can be quite difficult to help in terms of the diabetes control, because they've got a lifetime habit of eating, and that's where our issues can lie in terms of diabetes control. So these are the sort of symptoms that patients can get with diabetes. It doesn't mean they're going to get all 9 of these. Some patients have 1 or 2, others have the full Monty, if you will. If the patient is suffering with high levels of glucose in the blood, then they will drink a lot, because what the patient will feel is thirsty. So they'll drink a lot. I mean, by a lot, I mean liters. A patient of mine springs to mind whenever I see that slide. And she used to go to bed and drink 4 liters of water a night. That's a lot of water. Because she was drinking 4 liters of water a night, she went for a wee quite often. And of course, in the morning, by the time she woke up, she was absolutely shattered. So thirst, frequent urination, and fatigue are very often sort of three symptoms that make clinicians go, whoa, hang on a second, that doesn't sound right. They may get very, very hungry. They may suffer with weight loss. In terms of what you're doing, a slow healing sore or slow healing cut may be a sign that the patient is developing diabetes. So if, for example, you have a patient and, I don't know, perhaps they kicked a bed leg that morning and they've taken a little lump of skin off the side of their foot, you know, they've covered it over, you carry out your reflexology treatments, they come back and see you perhaps in 6 weeks' time and that cut is still there. So you're thinking, hang on a second, you know, that should be healing up by now. So that could be a sign for you to say to the patient, this cut is taking a little while to heal. What do you think that is? It may not be diabetes, but at the same time, it could be. So it's one of those things to just have in the back of your mind. There is some evidence if the patient is persistently high levels of glucose in the blood and basically out of control, then it does alter the pH or the chemical nature of the skin, and that can lead to a dryness and it makes the skin quite itchy as well. In terms of symptoms, what we see in the clinics is nerve damage, which, and I'll tell you a little bit more about it in a few minutes, but it means that sometimes, particularly the type 2 diabetes patients, remember they may have suffered with the condition for quite a while before they've had any treatments or any diagnosis. In some cases, we've had patients coming in because their feet are tingly or have pins and needles in their toes. And this is a sign that there's some, what we call neuropathy or nerve damage has already happened because of those continuously high blood glucose levels. And it affects the blood flow to the nerves, and the nerves don't conduct impulses as they should. So the patient can't feel things quite as they should. The same with eyes as well. You've got those little blood vessels at the back of your retina that take light in and convert it into images, etc. That needs a blood supply for that to happen. And that little blood supply, which is like tiny, really thinner than hairs on the back of your eye, they can get disturbed by high levels of glucose in the blood, and they begin to leak. So the patient gets blurred vision. So we're now getting quite a few diabetes patients who have been diagnosed after having seen a high street optician. So your Boots or your Vision Express, your Specsavers, all of those organizations now, if they see what they consider could be eye damage due to diabetes, it's something we call retinopathy, then they can have a direct referral into the diabetes or the eye clinics, usually, no matter where you are in the UK. So patients can be picked up with that. But sometimes the blurred vision can be age, it can be due to a whole number of things. But for those of you who have glasses, when you go in and get your eye test, not only will you read letters off the wall, but you'll have a little puff test, and sometimes the optician will shine a bright light into your eyes as well. And when they're shining that bright light in, that's what they're looking for. They're actually looking at the back of your retina for signs of things such as diabetes. And if they see something they don't like, they're able to refer it direct in. So it's not up to you, you will be referred in. So those are signs and symptoms of diabetes. We talk about ulcer. There's a lump of skin for you. The IWGDF is the International Working Group on Diabetic Foot. This is worldwide. So in terms of the international group, we break the world up into regions. So there's the South African region, there's a North Africa region, there's a Middle East, South America, North America, Canada, and each of these regions has a representative, and every now and again, well, every 4 years, they meet up and they create these guidelines. And in medicine, before we treat something, we have to define it. So according to that group, it's a break in the skin of the foot that includes the epidermis or the dermis. Go back to your anatomy. The epidermis is the very, very top layer of your skin, and the dermis is just beneath that, and the dermis is where you'll find your sweat glands, your blood vessels, and all those sensory cells that tell you about heat and pressure, all that sort of thing. NICE is the National Institute of Clinical Health and Excellence. That's based in the UK, and they produce guidelines on just about everything and anything that can affect the human body. So they have a guidelines for diabetic foot. They have another guideline for rheumatoid arthritis, for septicemia, etc. Every condition you can. So if you're really bored one night, you can go to nice.org.uk and find out what the guidelines are for whatever condition you want to think about. So in terms of foot ulcers, we've got around about, I think around about 30 to 40,000 ulcers being treated each week throughout the UK. So it's not highly common, but it is it's an avoidable issue that our diabetes patients suffer with. Why does it happen? Number one reason is loss of feeling or neuropathy. So with a high level of glucose in the blood, or persistently high levels of glucose in the blood, that damages the blood vessels that supply the nerves that supply the feet. So it means that the feet can no longer feel things around them. I'll tell you a little bit more about that in a few moments. One of the earliest signs is a lot of dry skin, and sometimes a patient can get a break in the skin, and that's a portal of entry for bugs and bacteria. Something important as well is to make sure that the patient's shoe fits as well. And what we do is, one of the problems with a lot of the patients, they don't check their shoes before they put their feet in. So if any of you are keen gardeners and you pop your wellies on, first thing most people do with the Wellingtons is they tap the Wellingtons out because they don't want any spiders or bits of dirt or stone in it. We should do that with everybody's footwear, specifically the diabetes patients. So if we can get them into the habit of, before you slip your shoes on, just give them a tap, make sure nothing's dropped into the shoes overnight, and then pop the shoes on. Because it's a good habit for everybody to get in, let alone just the diabetes patients. So I've mentioned peripheral neuropathy a few times, DPN. It's caused by damage to the nerves, and the first signs and symptoms are tingling or pins and needles in the toes. If the patient continues to have elevated levels of blood glucose, then that damage will travel back through the foot. So it'll be not just the toes, it'll be the front of the foot, and in some really bad cases, it's the whole of the foot. And when we say there's sensory disturbance or sensory loss, it means that those sensory cells no longer work as well. So it's always symmetrical, it's always right and left, it's like a mirror image. So if you get a patient who's got pins and needles in one foot and not the other, it's probably due to some other reason. With diabetes and the diabetic peripheral neuropathy, it's always both feet, and it's usually symmetrical. So it'll be the toes of both feet, or the toes and forefoot of both feet. They can't feel their feet as well. And one of the first signs is you may get some patients who are doing their shoelaces up extra tight because they can't feel the tightness. Something else we find in podiatry and foot health as well is, if the patients are not checking their shoes, all sorts of things get into their shoes. And we have patients walking around with bottle tops, house keys, staples, paper clips, Lego blocks, even drawing pins. And one of my examples when I'm doing the face-to-face talks is, we had a patient come into clinic a while back, many years ago, but it's stuck in my mind. And the reason for him coming into me was, my ankle clicks, but only in the kitchen. So it was a bit odd. We thought we were just trying to get out of the washing up. But taking both shoes and socks off, he had a drawing pin stuck into his left heel. It was pierced his left heel. He was walking around with a drawing pin in his foot. He lost sensation. He didn't know he had a drawing pin there. The reason why it clicked in the bathroom the reason why it clicked in the kitchen and nowhere else was because the entire house was carpeted. He liked to walk around barefoot, but in the kitchen they just had a laminate floor placed. So the only reason he knew there was something not quite right was because of the tick, tick, tick the drawing pin was making when he was clicking on the floor across the kitchen. He didn't suffer any pain. His body wasn't telling him there's a drawing pin in your heel. That's because of diabetes and because of neuropathy. Treatment was fairly simple: remove the drawing pin, clean it, and we checked on him in a few days. He was okay. But that gives you an example of how severe things can get with neuropathy. It happens to around about 25 to 40% of cases of our diabetes population. So it's, as long as they can keep good control of their glucose, they shouldn't end up with things like neuropathy or eye damage for that much as well. With diabetes patients, they're more likely to develop what we call peripheral arterial disease, or poor blood flow to the legs. And all of us, regarding whether or not we suffer with diabetes or not, as time goes on, we all will build up a little bit of plaque inside the arteries. And basically what happens is, if you have very high levels of glucose, that bounces off the inside of your arteries. And your arteries, don't forget, are delivering oxygenated blood from your heart down to your feet, well, everywhere else as well, but we're talking feet today. And that blood is pushed out of the heart in your heartbeat, so it's bump, 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 and it's pushing this blood out all the time. But with high levels of glucose, the glucose molecules bang off the inside of this artery as well, and they create a little bit of inflammatory response that makes the artery swell a little bit inside, and then things get caught behind that swelling, things like fats and triglycerides and all this sort of thing, and you end up with a buildup of plaque. And because that plaque builds up, it's a little bit like, if any of you live or work in a hard water area, you'll probably have to descale your kettle from time to time. Basically, that's what happens inside the artery. They get this buildup of material, so not enough blood gets through. Okay, what contributes to peripheral arterial disease? Number one is smoking. Nicotine within, as well as other cancerous products within smoke, when you inhale it, it shrinks the blood vessels down. It is what we call vasoconstricts. So that makes the blood vessels shrink to a smaller amount. The other products within the smoke, they also promote a buildup of plaque as well. So smoking is not good. It'll kill you, basically. Diabetes patients, when we say diabetes there, it's pertaining mainly to those patients who have poor control of their diabetes. So if you have high levels of glucose in the blood, they're much more likely to develop peripheral arterial disease. Things like high cholesterol as well, high blood pressure. We all get a little bit older, there's not much we can do about that. And for those patients who suffer with their weight as well, they get to a level where they're obese, they're more likely to develop peripheral arterial disease as well. So this is why you'll see government incentives about lower sugar in fizzy drinks, or they're thinking about stopping advertising for various high-fat foods. It's all trying to nudge us into a healthier lifestyle. Essentially, as a population, and I'm not making any accusation towards any of you here, but as a population, we tend to eat the wrong things and we tend not to move enough. That's why the government is pushing out various initiatives. Going on to skin, which is something we look at and deal with every single day. Normal skin, if you look at the picture on your left-hand side, the best analogy I've heard of is a brick wall. So you've got this is your epidermis, the very top layer of your skin, and each of those bricks will push against each other because they're full of water. Okay, that's why when we mean the skin is well hydrated, it means there's enough moisture or water in the skin. So those bricks are nicely inflated with water, and they push together and make a barrier. And the skin is there essentially to keep the outside out and the inside in. Okay, it's a nice protective barrier for us. And the reason it keeps well moisturized is because it has something called natural moisturizing factors, which these are chemicals that exist in the skin. Urea is labeled there. Around about, if you took a lump of skin out yourself and got it analyzed, around about 6 to 7% of the chemicals in there is urea, and urea basically keeps moisture in. It's not urine. Urine is pee or wee. Okay, urea is a natural moisturizing factor. So sometimes if you go into Boots or Superdrug or something like that, you'll see creams with urea in it. So if it's it'll have 10, 15, whatever percent of urea in it, and that's because we're trying to promote the urea content in the skin to help it maintain moisture in the skin as well. Ceramides are something else. You'll see some products like CeraVe, for example, has got high levels of ceramide in it to promote not just sucking the moisture in, but keeping it there as well. Okay, so that's healthy skin. If you look at dry skin, it means that those bricks aren't completely filled with water, so they're not pushing against each other so well, and that means there are microscopic channels for the water to escape, something we call transepidermal water loss. You don't have to remember that. But the trouble is, because things can get out, things can get in as well. So a diabetes patient who suffers with dry skin, sometimes it can be due to the diabetes itself and being out of control. They're more prone to things like fungal infections, so athlete's foot. They're more prone to bacterial infections and in some cases viral infections as well. Okay, so In terms of hydration of skin, it's nice to have a healthy looking shine on your face, and your hands feel nice and supple, etc. In terms of your feet, they need to be kept well moisturized and hydrated as well, so they can cope with the stresses and strains of walking. And if you maintain a well hydrated skin, then you're less likely to develop bacterial infections, fungal infections, etc. as well. Okay. Part of the issue with dry skin is it can very often be itchy, and the patient may even subconsciously start scratching their feet or rubbing their feet against each other, and that can break the skin as well. And we try and keep the skin in one piece, so we prevent portals of bacteria. Why do we get skin drying out? We've divided it into physiological and pathological. So physiological, as we all get older, we get a little bit drier, I'm afraid. So this is why a lot of the cream companies, the beauty companies aim it, shall we say, at a certain age within our population. Creams become usually more expensive and more prevalent as you get a little bit older. The menopause, there's a lot of work being done in menopause and podiatry at the moment, believe it or not. Obviously, as a bloke, I'm not qualified to discuss it from an empathy point of view, but when people discuss menopause, they tend to think, oh, it's you're going to reduce your bone density, you get some sweats, and you'll get these hot flushes. But menopause has a much more significant effect, and we now have evidence that in the perimenopausal woman, not only is she suffering with bone density loss as well, but there are changes to soft tissue. And there's something called, there's something called collagen in your skin. And basically that acts like almost like a scaffold, if you will. And that is weakened because you've lost that estrogen protection, if you will. So we know now that a lot of women sort of, on average, if you're going through menopause, it's around about 35 to 40 plus is when you can begin to get signs. You can get some unfortunate women who are going through it in early 20s, but usually it's 45 to 50 is when most women start to show signs. And one of the earliest things is a change in skin and skin tension and in skin hydration as well. Skin cleansers. If you're having a shower and you're rubbing your skin cleanser on, your what's it called, body wash, and it makes a lather, it makes bubbles. If it lathers, it dries. So what we say to patients is, by all means, clean. You've got to do that. Make sure you wash it all off afterwards. Okay, and by all means, apply a moisturizer once you've dried your feet as well. Sun exposure. Most patients forget to put sun protector on their feet. So we very often we have a really good idea what their flip-flop was or their sandal because they've had sunburned feet, and you can see where the straps were. So we encourage people to use suntan lotion on their feet as well. Most of them contain moisturizers these days. And if you work in a temperature-controlled environment, be it central heated or air conditioning, that can dry the skin out as well. Pathologically, you'll see there's a range of conditions there that can all promote dry skin. So if any of your patients do suffer with any of these conditions, they will start to moisturize their skin. People will automatically moisturize hands because it feels better, it feels nice, and they'll moisturize the skin because obviously that's what people see. But a lot of people forget to do their feet. So diabetes, you're more at risk of developing dry skin. With eczema, for those unfortunate patients who do suffer, eczema can be triggered usually with allergic reactions. And one of the more common side effects is a dry and itchy skin. Psoriasis, we discussed earlier. Peripheral vascular disease, that just means there's not enough blood getting down to the feet. So if there's not enough blood there, then the skin isn't able to flourish as well. Anemias, that's another blood condition. Renal failure or kidney failure, if you will, that's another reason. And in some cases where the patient's unfortunate enough to be diagnosed with cancer, some of the chemotherapy drugs that are delivered will dry the skin out, very often within 24, 48 hours. So it just gives you a little bit of an idea of why skin would be dry. So at this point, you're thinking, oh, good grief, there's all this going on. What's it got to do with me? So what we encourage everybody to do is to ask their clients, do you suffer with diabetes? These sort of things can turn up in the middle of your screen at the moment. You've got a wound. Obviously, if you come across something like this, refer it. Get it up. It's not something for you to deal with. You need to say to your patient, did you know you've got a nasty little wound on top of your toe there? And they may not even realize it. They may have neuropathy or nerve damage, so they can't feel it. They might have eyesight problems. They might not be able to see their feet. Okay, so if you do see a wound like that, you'll say to the patient, look, you've got a nasty wound on your feet. You really need to pop down to to your GP. Now, I do realize GPs are a rarity in this country. They can be difficult to get into. If the patients, depending on where they are, A&E is another place to go, but also minor injury centres may be an option just for quick treatment. Now, that's not something to be dealt with in the minor injury unit, but if a nurse in the unit sees that, they'll refer them on for you, so it can get you through the barriers a bit quickly. Picture to your left-hand side, that's a pretty grossy looking nail. That's a nail fungus or onychomycosis, if you want a proper term. Usually a patient would have suffered with a fungal skin infection before it goes to the nails. And in most cases, if there's a nail infection, it tends to be 1 or 2 nails on both feet. It's very unusual to be all 10 nails. There are treatments for this, over-the-counter ones. That's a pretty significant infection, which would need some intervention there from either GP or podiatrist. But very often it'll be just a discoloration of the nail. It could be usually a yellowish or light brownish tinge. And if we catch it early enough, it's relatively easy just to treat. But the problem is it needs the patient to continue treatment, and very often they get bored. They don't carry out the full term of treatment, and that's why the infection spreads. Again, this is another patient with fungally infected nails. The reason we've shown this is we're becoming more aware that patients with dark skin tone will exhibit different presentations of conditions. So if, for example, you're looking at the picture there, this labeled toenail fungus, that's obviously a Caucasian foot, and you'll see some inflammation around the end of the toe. That inflammation isn't always as obvious in a dark skinned patient. So sometimes it'll show up as almost like a grayness or a blueness. So there's a big push within health all around the world at the moment. If you do have patients with dark skin tone, to spend a little bit extra time looking around, because in Caucasians it's easy. If you've got inflammation, one of the signs of inflammation is redness, but in a dark skin tone, that redness isn't always displayed as redness. So throughout all of the health economies throughout the world, there's a lot more attention now being paid to patients with dark skin tones, because we've been missing things. Let's be honest about it. This is athlete's foot, or tinea pedis, if you will. It's not a serious condition, but in a diabetes patient, it can mean if they do scratch their feet because it's quite itchy, they can break the skin if they've got rough nails, etc. So over-the-counter powders and sprays are usually okay to treat this sort of thing, but if it persists, then ask your patient, have you seen a podiatrist? And that podiatrist, she or he, can recommend some treatments. And the last 2 pictures are heel fissures or cracked heels. Top right is a study that a company I'm involved with, we're doing in Chennai in India, and bottom right is a Caucasian heel, just to show you how the 2 present. The guy with a sort of turquoisey background to him, his heel fissures are much more severe than the bottom right picture. But again, because of that dark skin tone, you can't always see the difference. So this is why we need to take a little bit more care with those patients. So these are quite severe heel fissures. This will need some pretty intensive care with some, if I could call them, specialist creams, but also in some cases we can put dressings on to try and close those wounds over as well. But if you see anything like this, basically refer it. You're there to carry out reflexology. You're there to make the patient feel more comfortable. I've undergone reflexology myself, having been in podiatry for many years. I must admit I was quite skeptical. So I got, I think it was a Christmas present one year. So I went and had a reflexology treatment just to see what it was like, really. Absolutely fantastic. My only problem was the reflexologist teaching me said that I wasn't a perfect client because I didn't stop talking. Apparently you're supposed to take quiet and be relaxed, but as you probably gathered by now, I tend to talk a lot. But yeah, and she picked up the fact that I'd had back pain, and she also picked up the problem. She said there's a lot of tension in various parts of the body. I'm thinking, cracky, how'd you know that? So yeah, went from being skeptic to being very impressed with that young lady, to be perfectly honest. But in your position, if you see something like this, is the patient aware of it? Did you know you had a wound? Did you know it looks like you've got very dry skin? It could be a fungal infection. Have you had a chat with somebody? Okay. Is anybody else aware of this? The places to refer to, you may have a local podiatrist on the high street next to you or within your village, town, city, whatever. GPs, if you can get in there, fine. But if you do find somebody with a wound, then yes, GP is ideal. A&E, that could be hours, but you can cheat a little bit and send them into the minor injury unit as well. Don't forget that. So what we're after really is for you to communicate. And also what we're after is persistent reinforcement with patients. Look after your feet. And we say with all of our patients, but particularly the diabetes patients, is wash and dry the feet every day. Dry carefully, especially between the toes. Pop a bit of moisturizer on, fresh socks, and check your footwear. Whilst they're drying their feet and washing their feet, if they see anything they don't like the look of, any signs of bleeding, anything dribbling out from somewhere that shouldn't be, to let people know. That's it. Those 5 things is what we preach and teach every single patient. You've got 5 digits in each hand, 5 toes on each foot. So there's 5 things to do each day to protect their feet. And if we get all our diabetes patients doing that, we will prevent wounds. I'm not going to show you pictures of nasty wounds, but a lot of them are because the patient didn't look at their feet each day, or they didn't tap their shoes out and find that bottle top coin. We even had a patient, the practice nurse in Norwich told us that when she tapped her patient's shoe out, she found a little jam jar came out the top. He couldn't feel it. He'd actually walked to her clinic for a diabetic foot check with a jam jar in his shoe. When she asked him, did he have any difficulty putting his shoe in? He said, yeah, it took a bit of getting in there, but I got my feet in and I walked down to you. But he did that with a little posh jam jar you get from the hotels in the front of his shoe. And again, with the diabetes patients, if they're saying, oh, I got to go and see the nurse again, I can't be bothered, encourage them to go for their checks, because we do the checks for a reason. It's there for early warning systems. And if we can catch something earlier, it's the same with all conditions. The earlier we catch it, the better we can look after it. Simple as that. And you're there on the front line with us. So if you see something you don't like, shout about it. Tell the patient, tell them to get to see the podiatrist or get to the GP or A&E or minor wounds unit as well. The sort of thing we're looking at is something as simple as this. And maybe to many of you, you may think that's just a little crack. But in the diabetes patient, that's a portal of wound. Sorry, that's a wound. That's a portal of entry for bugs and bacteria. Okay. And I can think of 2 patients of mine, they no longer have their big toes, they've had to be amputated. And both of them started with that little crack. And again, if they'd seen them sooner, instead of waiting for it to ulcerate and get to a point where we just couldn't rescue the big toe, if we'd seen them 3-4 weeks beforehand, we could have addressed that wound, healed the wound, and they'd still be walking around with 5 toes. And you can appreciate, if you lose your big toe, it does make walking a little bit more difficult. It's not impossible, but it does make it a little bit more difficult. So once they wash and dry carefully between the toes, pop a bit of moisturizer on. The moisture goes on the bottom of the feet. It can go on the top of the feet. Do not put moisturizer between toes. In between the toes is usually moist and dark as it is. We don't want anything else going in there. And ideally, if they can get a cream with a glycerin base, ceramide or urea, it should be non-greasy and it should go in nice and quickly as well. Okay, we're not here to promote various products or specific creams, but it should be a good quality cream, urea, glycerin, ceramide cream. And finally, hopefully I haven't scared you to death, but if this has piqued your interest professionally, or you may have people in your family thinking, oh gosh, cousin Dave has diabetes, I want to help him more, etc. Then we do run foot awareness courses. These are designed for people within your beauty and holistic therapy sectors. we're not going to turn you into clinicians. You're not there to diagnose. It's just to give you a little bit more background. Because sometimes if you understand why you're referring people, then with a better understanding, you're a more informed therapist, and a more informed therapist will look after their patients or their clients in a better way. So we do virtual ones. We can do face-to-face, which is usually much better. And when it comes to the face-to-face discussions, it's usually hands-on, socks off, and we look at each other's feet so we can discuss things as well and make you feel a little bit more comfortable. But what I wanted to stress to you is diabetes, it's prevalent in around about 7% of our population. The vast majority of diabetes patients will live a full and healthy life, but if they have poor control of their diabetes, that's when problems can happen, and that's when early intervention will make a huge difference. I'm not going to put too fine a point on it, but if you get a patient in and you start educating and really pushing them, and they start washing their feet, drying their feet, moisturizing their feet, checking the shoes, you will have saved a limb and possibly saved a life. I'm not overstating it. So welcome to the world of diabetic foot. And if you've got any questions, please feel free to ask.
That's fabulous. Thank you, Gareth. So the message is you absolutely can and should treat a diabetic client rather than turning them away, but you should be giving them the advice that's on there. And I'm going to create, for those people that joined us live, I'm going to create a little leaflet that you can actually give your clients to take away. So I'll do that on Canva and send that to you, those of you that have joined us. Has anybody got any questions? I'm sure there might be lots of questions. Alison, would you like to unmute yourself?
Yeah.
Hi.
Can you hear me?
Yeah.
Yes.
Yeah. So if you've got a client and they've got a lot of dry skin, do they need to remove that dry skin before they moisturize? Say
No.
No. Okay.
No, we prefer patients not to start treating themselves. Part of the problem is there's some very good creams out there that will help them recover from dry skin within a matter of days. But if we say to them, or if you remove your dry skin for us, they'll not only go for the pumice or the file, they may get something with a blade on, and we don't want to do that. So we just say that if you've got dry skin, get some cream on there. But if it's symptomatic, so if they're getting lots of hard skin or calluses, then pop and see their local podiatrist.
Okay, thanks.
And Gareth isn't allowed to promote products, but I can, so. And we work with a range of FootLogix products, which are super duper amazing. Unfortunately, you can't access them unless you've done a pedicure training course, but there is a way around that. And depending on where you are in the country, I have got trainers that could potentially do that, but that's a different story for another time.
Yeah, I've seen the FootLogix. It's I can't remember the name of the woman who was inspired to create them, but there's a whole range, and she has appeared at a Foot and Ankle show, which is a conference held up in Liverpool every year or so. So I'm aware of the FootLogix, and she does have one for dry, cracked skin, which is quite high concentration of urea, so it is an effective cream.
It's quite magic. I use it a lot on my clients, and it is magic. You know, a client will come with really peely, flaky skin that if they try and remove themselves, it won't come off anyway, because it's not dry, hard skin. It's actually a fungus. And a month of putting this mousse, which is completely dry when you put your socks on, it's gone, completely gone. And she's got cracked heel stuff and all sorts. It is magic. Yeah. So I am setting up some kind of affiliate, because not everybody wants to cut toenails and do all of the kind of the wet things. But if you want to recommend products to clients and they order them from the website, then you will get a commission to do that. So that's my way around it. But that's coming for about October time. Okay. Any other questions? I have got one in the chat. Where are we? Oh, my chat bottom won't open for some reason. Oh, there it is. There's my chat.
Oh, Fiona, yes, you're quite right. Neuropathy or lack of sensation, yes, it can happen in multiple sclerosis. It's also prevalent in something called vitamin B12 deficiency, chronic kidney disease, chronic alcoholism. There's a whole array of conditions that can lead to neuropathy in the feet. But yes, you're quite right.
Yeah.
I'm sad you've learned that personally.
Fabulous. Lynn, have you got anything else that you'd like to say? I'll put a link to your website and obviously the course that you do as well. I'll put that all in the show notes when I upload it. But that's great. And if anybody's got any questions, or they've got a client that they are thinking might be diabetic, or next time you see them you're a bit concerned, do message me and I can get answers. Garath is absolutely brilliant with his drive. Sent you a couple of pictures before, haven't you? Gone, oh, not sure about this. Yeah, very, very, very helpful. Obviously,
also, if I could just add, if you can't find a podiatrist or you're getting frustrated, do get in touch with Louise, because I've been around a while. I know a lot of people, so I will know a podiatrist near you. So if you get a bit frustrated, you can't get an answer or something, then just let us know and we will help you.
Yeah, you do have to be careful and do your research with links. I sent one of my clients to a podiatrist and I very specifically said, this is the one I think you want to go to. She couldn't get in with that person for about 2 months, so she went somewhere else, and then she rang me about a month later and she said, I can't have my next appointment. I've got infection in 3 nails and they're completely bandaged, and this chiropodist, podiatrist, don't know what the name of the person was, or they're kind of like the genre of training, actually butchered her nails. So you do have to do your research and find somebody.
Yeah, if you're looking for a podiatrist, then they will be registered with the Healthcare Professions Councils.
I think this person was.
Yeah. Oh.
Which is very worrying, but yeah.
Yeah. Well, if that was one of my patients or somebody known to me that had been referred, then I have a course. If you're concerned about, nothing to do with diabetes for a minute, but if you send up your patient to a HCPC registered podiatrist and that podiatrist is not doing a good job, you do have the ability to report them.
Yeah, and that's the good thing about having a professional standards authority, which is we've got CNHC, and that's for the same thing, but we don't cut things off, so it's not quite so
No.
desperate.
Yeah, there may be a few out there that in the wrong profession. I think the vast majority of us are pretty good, but yeah, there are 1 or 2.
Yeah. But we're all here to help, whatever questions anybody's got for anything. So thank you so much for joining us today. Yeah.
That's like, yeah. Can I just add, Louise, that on the course on the that's on the Therapy Learning Resources website that Garath referred to, is that there's, as well as just the sort of the learning element of the course, we do try and signpost you to lots of other resources. There's various things there that you can download. Sorry, my camera's messing about today. But yeah, you can sort of, you know, we're very good at trying to help you with your onward learning, with your communications with your clients. So we do signpost you to other leaflets that you can order and have them sent for free. And there's things that we've developed that you can print off as well. So we try and give that full support that you might want. And don't assume that you might have asked somebody previously that they've got diabetes, that's on your records and they've said no. It's worth asking each time, because obviously with type 2 in particular, that could have come on.
Absolutely. Brilliant. And I'm looking forward to organising a date where we can do a practical workshop looking at real things on feet and testing for neuropathy and things. That's
just a quick word about the courses as well. They're very informal and we try and make people relax. We're not trying to turn you into clinicians or diagnosticians. It's nice and relaxed. As far as we're concerned, you're part of the front line. We just want you to be informed in a comfortable and relaxed manner, whereby you can approach your clients with a little bit of confidence and improve those clients' well-being.